The topic of the presentation is considerations for alcohol use disorder care among youth aged 12 to 25. Next slide. I'd just like to start by acknowledging that today's program is made possible through financial contributions from Doctors of BC, with support from the BC Ministry of Health and Ministry of Mental Health and Addictions. And also a tremendous thank you to the BCCSU medical writing team for their support developing these slides and their flexibility with adjusting some of the content and some of the topics today. Next slide. My speaker disclosure is that or perhaps I'll start with my background. I am the clinical lead of a new service at BC Children's Hospital called the Substance Use Response and Facilitation, or SURF service, where we see youth admitted to hospital with substance use presentations and adjacent presentations. I also work at Vancouver General Hospital on the Complex Pain and Addiction Service and hold a couple of medical directorship positions. By training, I'm a psychiatrist with designation in adult, child and adolescent, as well as addiction psychiatry. And through this work, I have some disclosures in working with Otsuka and Lundbeck Pharmaceuticals. And I've also received a grant award from Vancouver Coastal Health. Next slide. As part of our disclosure of commercial support, the ECHO team discloses support from some of the groups that I mentioned earlier, as well as in-kind support from the BCCSU. For your awareness, all content that has been put together that's developed as part of the program has been reviewed for bias and has been validated by a couple of groups, an independent scientific planning committee, as well as the College of Family Physicians of Canada, and to this effect is approved for accreditation and submission. So with that, we dive into the learning objectives for today's presentation. And at the end of the session, my goal is for you to be able to firstly describe patterns and rates of high-risk drinking and alcohol use disorder among youth. Secondly, to compare and contrast some differences in working with adolescents and young adults compared to the adult population in screening, diagnosis, and treatment. And further, apply some considerations and strategy in order to engage youth in care who may have high-risk alcohol use and meet criteria for alcohol use disorder. I'm going to start with a definition here. As we talk about youth, this represents a large age demographic of individuals aged 12 to 24. And that's in comparison to adolescents who are between ages 12 to 17 and young adults who are aged 18 to 24, where adulthood starts in age 25 and above. I make this distinction for a few reasons. And certainly we know that all youth still have developing brains, which continues through to the mid-20s and young adulthood. But young adults are also a unique demographic in that they tend to be the group that drinks the most, and they are of legal drinking age in comparison to adolescents. And there's a challenge in that there can be a clear lack of guidance about how to manage young adult alcohol use, in part because it's uncertain whether they should be included with adolescents or adults, depending on the treatment approach. In Canada, we receive recommendations about alcohol usage and safe drinking recommendations from this group, the Canada's Guidance on Alcohol and Health. This actually has been updated earlier this year, and the most recent update has removed distinctions between gender groups and age groups on low risk limits. And essentially what it emphasizes is that when it comes to consumption of alcohol, less is really more. And that's something that I talk about with all of the patients that I work with in the addictions field. This guidance comes from a recognition that the higher the average weekly alcohol intake, the greater the risk of certain medical conditions, such as heart conditions, certain types of cancer, and strokes. And also that the higher the alcohol intake on any single occasion, that's associated with a higher risk of injuries, violence, deaths, such as from alcohol poisoning or other risky behaviors. And so we really think about this as we provide guidance and guidelines about alcohol usage with youth. If we look at trends of alcohol use over time, what we see is that there, over the last number of years and since 2008, there's been a steady downward trend in alcohol use for individuals aged 15 to 19. And that is reflective of successful public awareness campaigns, dissemination of information about alcohol use on the developing brain and downstream consequences. But if we look at the next slide, we still see that there's a relatively high prevalence of what we would consider high risk drinking in youth and young adults. So of youth and young adults who reported any alcohol use in the last 12 months, about 12% of adolescents and almost 30% of young adults will consume alcohol above these low risk drinking guidelines on a weekly basis. A sizable percentage of these same individuals, about 7.5% of adolescents and 23% of young adults, actually exceed the low risk drinking guidelines on any single occasion, which is something that we would frequently term a binge use of alcohol. And so what we see is that alcohol is the most commonly used substance among youth, and that's followed by other substances as well. And so many youth who use alcohol will mix this with other substances such as nicotine, and that can be through the use of cigarettes or non-combustible tobacco such as vaping. Cannabis usage, also through smoking and other mechanisms and non-combustible usage, as well as caffeinated beverages and other energy drinks. And the reality is that many youth who use alcohol may use other substances besides these, but these are the most commonly used. Next slide. So as we think a little bit about some key differences between youth, young adults, and adults, we know that youth who consume alcohol may be at a heightened risk for certain types of behaviors and health outcomes. And so when we look at youth alcohol use in comparison to adults, we know that binge drinking is more likely. And that's also associated with the converse of having periods of abstinence of no use of substances. And so youth are going to be less likely to present with withdrawal symptoms, and further may not disclose withdrawal symptoms when those are occurring. Youth may use, as we've already talked about, may use substances with other drugs or in other scenarios. And so polysubstance use tends to be more common. And adolescents, in comparison to adults, may have a reduced likelihood actually to seek treatment. And that can be for a number of different factors. Stigma is a big one, fear, and certainly concern about reprisal from parents or other adults. And the downside of that is, as I mentioned, that there are some particular risks to youth who use alcohol, and that includes a number of different things. There's negative effects on brain development, which continues through the mid-20s. Alcohol use and substance use in general can be a marker for risky decision-making, such as drinking, driving, access to and interactions with individuals or environments that they wouldn't have previously, and also a high likelihood of drinking quickly, which is associated with risk of injury and alcohol poisoning. And lastly, the early adoption and initiation of substance use before the age of 18 is highly associated with development of moderate or severe alcohol use disorder. So use of alcohol below the age of 18 is associated with a 6.5-fold increased risk of development of substance use disorder in the future. And we know that about 90% of all substance use disorder diagnoses have an origin in adolescence. So it's really important to think about that. So this brings us to our principles on the next slide. Especially when thinking about substance use and treating this in adolescents and youth. And some of this has some overlap with adults. We recognize that substance use disorders are chronic and relapsing conditions. And so we need to think about using multiple treatment approaches. And that includes a continuum of care. We can click through to number 2, a continuum of care that's inclusive and supportive of long-term recovery.
Sorry, the animations aren't working on my side either. Sorry, everybody. These should be animated, but they're not.
They should be popping up as I say them. So, and this is, I think, number 3 is particularly important. for youth and individuals who have recently adopted use of substances. So early intervention really should be emphasized when providing care. And I would add to that youth who may not meet criteria for a substance or alcohol use disorder may actually benefit from intervention to prevent them from developing in that trajectory in the future. In order to do that, we need a full range of treatment approaches to be available, and those should be tailored to the patient and target the holistic needs of the patient. So recognizing who we have, what their psychosocial and concurrent disorder concerns are, and what their values and goals are in order to tailor our approaches and guide our psychosocial interventions and supports. The last couple of details is that care continuity should be a priority. So as youth get older and start to age out of services, we are able to appropriately support them so they're not losing out on services and the support that they had. And as part of a standard of care, education and referral to harm reduction services should be offered. So the pathway for assessment and diagnosis and treatment of alcohol use disorder begins with screening and brief intervention. And so as we recognize different components of alcohol use, for example, presence of alcohol withdrawal, we want to develop a treatment plan for that. And shift the treatment plan and be more inclusive of different types of modalities, such as pharmacotherapy, community-based supports and programs, as well as psychosocial treatment, while ensuring that we're steeping all of that in a patient-centered, harm reduction and recovery-oriented care model, where these strategies can be offered and shifted to or added through any point in the care pathway. There's a comment that cultural-based recovery programs are going to be important, and I would add not just for Indigenous folks, but we want to make sure that we're thinking about a cultural perspective for everybody that we're working with. On the next slide, just a focus on SBIRT, which is screening, brief intervention, and referral to treatment. I highlight this as a framework that actually is designed for the prevention, early intervention, and treatment of problem behaviors that consists of a number of components. So firstly, involves screening all clients as they enter non-specialized settings. And then depending on the information that's gathered, providing certain types of intervention, brief intervention, for example, and then further referring them as appropriate based on their specific need and to appropriate levels of treatment. And it's an opportunity to engage individuals in care for a discussion about a problem that maybe they weren't necessarily seeking help for. And it's been very widely used to identify and treat risk and particularly high risk use of alcohol and illicit drugs. So I mentioned that the process consists of universal screening. And so in this case, we would do that to assess for patient alcohol use. Positive screening should be followed by brief intervention. And what we should aim to do with that is to increase an individual's motivation to make some changes to their substance use. And it involves teaching behavioral changes and giving information that may shift the stage of motivation and stage of change. Harm reduction approaches absolutely should be included here. And for your awareness, most brief intervention, it's not very time consuming or onerous. It usually can last for 5 to 10 minutes for those with low or medium risk of problem behaviors. And for those who have identified alcohol use disorder or at a higher level of risk, referral to treatment may be helpful and help support them in accessing more intensive treatment. The last component of SBIRT is, as we talked about, these are starting in, for example, community or emergency or other other non-specialized setting where it's important to follow up to ensure that treatment is actually achieving the patient's goal and in line with their priorities. On the next slide, we talk a little bit about screening, which currently is recommended to occur on an annual basis in adolescents, young adults, as well as adults. The guideline from the BCCSU actually recommends use of the NIAAA tool and I'll show that in just a moment. It's short, it's specific to alcohol adolescents, and it's been robustly validated, but there are a number of other screening tools. And the way I sort of think about this is we really want to think about a tool, asking about this on a regular basis with the youth that you work with, and getting comfortable with a particular tool with a little bit less importance on which screening tool you're using in particular. And that's because there's a number of screening tools and there's a lack of clarity about which should be used, how they may differ from one another, and some age cutoffs as well that you should familiarize yourself with. I also add that the reason we talk about using a validated screening tool is that as healthcare providers, we are not great at assessing for youth substance use. We tend to use impressionistic diagnosis and values-based judgments, such as this is a good kid, they're doing well academically, they probably are, and making assumptions that they probably aren't using substances. So we're probably missing a key component of our patient population that may be using alcohol, other substances, and as we mentioned, that could be a hallmark for other risky behaviors. So on the next slide, we look at the NIAAA tool, which is a 2-question screen. It starts with a less threatening introduction to the topic, in which we ask an adolescent about alcohol use in peers. And then we transition to a second question, asking about the frequency of use, about the use of alcohol in the past year, and providing some recommendations about a high-risk threshold, depending on the different age categories. And that can certainly be pulled into the SBIRT model. On the next slide, we think a little bit about diagnosis of alcohol use disorder. So after identifying youth with high-risk drinking, and this is true also for adults, we should assess in more detail for an alcohol use disorder using the diagnostic criteria in the DSM-5. Of note, the DSM-5 is validated in adults. There is less robust evidence, and the criteria were not specifically designed in mind with adolescents or young adults. And so it can be more difficult actually to identify a diagnosis of AUD in youth. And there's a few reasons for that. We talked about the infrequency of use or the high rates of use less frequently. Youth have many safeguards in their lives, parents, coaches, teachers, who may limit some of the natural consequences from occurring. You know, you have a big night, you party, you don't wake up to your alarm clock for your work shift the next day, but mom comes in, is able to give you a right to work. So you really have to think about some of the risks and some of the other scenarios that youth may get themselves into associated with alcohol use in order to appropriately and accurately identify criteria. So it can be difficult for mild alcohol use disorder and to differentiate that for high-risk drinking. And in this scenario, you really want to think about offering education and safer use strategies and really be sure to follow up with the patient to assess for changes in alcohol use. On the next slide, a further consideration for assessment, and this is something that as a psychiatrist and somebody who really focuses on presence of concurrent disorders, it's really important to think about the presence of concurrent mental illness when discussing youth substance use. So I highly encourage clinicians to screen for mental health problems, and that's because youth aged 15 to 24 are more likely than any other age group to report the concurrent presence of mental health and substance use problems. Depending on the setting, prevalence rate vary from between 50 to 90%, and that higher number, where it's almost a one-to-one link, occurs in treatment-seeking youth. Some of the most common diagnoses that occur in youth with substance use disorders include what we term the disruptive behavior disorders, such as ADHD, conduct disorder, oppositional defiant disorder, but other diagnoses such as depression, anxiety disorders, PTSD, and the presence of adverse childhood and traumatic experiences also will have an impact, not just on the development of a substance use disorder, but also the adherence to treatment, ability to relate to their and attach to their treatment team, and also to be retained in treatment over time. Next slide. So for all youth who are identified to drink above low-risk drinking guidelines, we recommend brief intervention to be offered. And
sorry, it's Christina here. I'm just letting you know we have 2 minutes left,
okay.
And I quite a few slides, so I wanted to give you the opportunity to prioritize your favorite slides.
Yeah.
Thank you.
So I'll go through this pretty quickly. So for youth with brief intervention, we really want to think about having a brief discussion with a key message about trying to postpone alcohol usage until the brain is further developed. And for youth who plan to continue drinking, we can engage in harm reduction strategies. Some suggestions include drinking in a safer environment, alternating with water, eating food, trying to limit the amount that they're drinking, and certainly thinking about safety. So not drinking and driving, and trying to limit the use of other substances. On the next slide, we talk about withdrawal management, which is going to be quite similar and should be offered to youth as well as adults. The pharmacotherapy is going to be similar. Here, I think the takeaway point is, while withdrawal management is important, it's not treatment or care in and of itself. The next slide talks a little bit about pharmacotherapy, which should be paired with psychosocial interventions. And that's what the next couple of slides will talk about, where we really want to think about cognitive behavioral therapy, family-based approaches. And it probably matters less about adherence to specific treatment plans as it does skills development, understanding what driving factors for alcohol use may be, and helping provide support in those ways. And can be paired with pharmacotherapy, and both should be utilized as much as possible. Community-based supports are also highly underutilized, and youth may not get as many referrals, but there are youth-facing AA meetings, smart groups, and these rely on principles that substance use can be highly isolating. We want to think about the development of sober communities, sober relationships, and engagement in other recovery-related behaviors, engaging in the community to reduce the amount of time focused on substance use behaviors. On the next slide, there are some strategies here. I think that these are strategies that are going to be of importance for use with any patients that we're working with across the healthcare system. But in particular with youth who are in treatment, we want to think about confidentiality, balancing that with involvement of family, which is a cornerstone of youth substance use treatment. And really, motivational interviewing can be a very youth-centered approach in line with youth development to be able to help the young person that you're working with make decisions about what their goals, their priorities are, to allow for motivation and change, and then over time to allow for continuity of treatment. These next strategies also go alongside that. I'll leave the summary, and there's just some resources there for the group as well.